My name is
Yes,
Daniel
sir.
Lauffenburger, and I'm currently a third-year medical student at Arkansas College of Osteopathic Medicine. My case report is titled Hypocupremia, a Sequela Bariatric Surgery, and it follows a patient that I had the pleasure of seeing in a family medicine clinic in Arkansas. So I'd like to first discuss what copper is and how important it is. So copper is a vital transition metal for the overall structure and function of several enzymes involved in general metabolism, oxidoreductase activity, gene expression, collagen and elastin synthesis, neurotransmitter synthesis, and iron metabolism, among several other things. This element can be found in a variety of protein-rich foods, including fish, organ meat, nuts, seeds, and green leafy vegetables. Given its abundance in several food groups, it's actually pretty rare for humans to develop copper deficiency in the absence of cases of malabsorption, Menkes disease, or those taking zinc supplementation, as zinc will actually compete with copper's absorption in the small intestines. So one of the most common causes of a copper deficiency is a malabsorbed state, like in a patient with a history of Roux-en-Y gastric bypass surgery or RYGB surgery for obesity. In the sparse cases of copper deficiency, symptoms can include anemia, neutropenia, osteoporosis, hypopigmentation, hypercholesterolemia, myeloneuropathy, and even disruption of thyroid function, which we've possibly seen here. So the patient that I present today is a 59-year-old Caucasian woman with a history of Roux-en-Y gastric bypass surgery who came to see her primary care physician for routine follow-up on her chronic hypothyroidism. She was originally diagnosed with hypothyroidism in her 20s when she had an elevated TSH and a low T4. Even with reported adherence to her levothyroxine 200 micrograms a day, every morning with water 1 hour before breakfast, she still presented with dry skin, fatigue, brittle hair, and cold intolerance, which are the classic symptoms of hypothyroidism. A physical exam revealed that her thyroid was not enlarged with an absence of masses or nodules, but rather symmetric and non-tender. Her hypocupremia, or copper deficiency, was actually incidentally found while investigating the cause for her abnormal liver enzymes seen on a routine comprehensive metabolic panel, warranting further workup, including a liver ultrasound and additional labs. She had a serum copper level of 40 micrograms, which the normal is like 70 to 175 micrograms per deciliter. And she was informed by her primary care physician to increase her dietary copper and to follow up in six months to recheck her blood copper level. But unfortunately did not follow up until 3 years later that showed a copper level of 36 micrograms per deciliter. At this point in time, her TSH level was elevated at even higher than 150, with the normal being 0.4 to 4.5. And a free T4 was low at 0.3, with the average being around 0.8 to 1.8. Even while taking levothyroxine 175 micrograms 3 times a day for a total of 525 micrograms. She was referred to an endocrinologist who assumed she was non-adherent to her levothyroxine, as well as to an infusion center to see if she's a candidate for IV copper infusion. So I'd first like to discuss how a Roux-en-Y gastric bypass surgery leads to malabsorption. So this type of surgery typically bypasses the duodenum and sometimes portions of the proximal jejunum, as you see here in my little diagram. These are the key locations for the absorption of copper in the digestive system. And after a bariatric surgery, most patients are informed to take supplemental vitamin mineral preparations. And most of these preparations actually have an inappropriately high zinc to copper ratio. And it has been shown that the excessive zinc supplementation in that preparation will interfere and compete with the copper absorption. So most patients are not educated or know to take the copper supplementation, as there's limited information and awareness of the possibility of copper deficiency in an RYGB surgery. Copper deficiency is usually treated with oral and parenteral copper supplementation in the form of copper gluconate, copper sulfate, or copper chloride until adequate copper levels in the blood are attained. So my report pretty much just serves to advise for the greater attention to the possible signs of hypocupremia in patients with a history of or receiving RYGB surgery. Data from the CDC shows an increasing prevalence of obesity throughout the United States, which suggests that there will be more candidates for Roux-en-Y gastric bypass surgery, and thus a potential for a higher incidence of copper deficiency in the United States. Once again, signs of copper deficiency include, but are not limited to, hematological abnormalities like anemia and cytopenia, thyroid dysregulation, as possibly seen here in my patient, neurological manifestations, hypercholesterolemia, hypopigmentation, and much more. While some of these symptoms can be completely reversed, like the hematological manifestations, the neurological effects, like the myeloneuropathy, may not be fully reversible, as seen in literature. Given the rarity of this condition, we advocate for greater awareness of this potential side effect of bariatric surgery, as well as to advocate for potential side effects, as well as to advocate for future studies regarding the optimal methods towards treating and in an effort to diminish future systemic complications of bariatric surgery. And that's my presentation. I'm open to any questions